Welcome to Good Morning Niger Extra. Thank you so much as you join me for Inside this morning. So today for Inside the show, I carry very bad time for me to come with your domot because you know we say they talk say health now wealth because now who they alive now carry first. If you know they're alive, now you know sha. My name is Precious Enyi and they always give me happiness to be for your domot every single day. Today I will tell you the person will be say go follow me sit down and talk this matter. But what's the matter I won't talk about? I won't talk about to access healthcare for Nigeria. That one a well body matter because the way the thing they go they don't jackpot. How this jackpot then use the affect us? What be the main reason we make doctors the jackpot? We make and can they even affect us? How person feel use access medicine for inside Nigeria? Or you know well how you go take use access hospital and then waiting be the challenge then we if you know fit access them and waiting be the solution because for every problem there must be a solution. That's not the matter I want to talk about. But you know what? I go tell you who my guest be after the break. So I tell you, say, I get ogbonge doctor will go follow me talk this matter where I get so. Because it is very important to make we know when it don't they do us for head, where we go. When they do us for leg, where we go. When they be saying a matter, where we go. What be the things and what we need to do to use take care of our body, to make sure say our body they kajad well. Now make a carry person will be say he himself na general physician. That is doctor will be say they take care of everything we get to do with the general well body of our body. In name now Dr. Paul Kusemiju. He follow me day for inside the studio for us to learn about this matter. Dr. Paul, thank you so much as you're welcome. I call the name well, Kusemiju.
Yes.
Thank you very much. I'll be sitting down for front of class. Don't tell me it's because of my height. It's not be said because I need to see road, but because I get something inside the head. Thank you. Thank you. So more look at accessibility to healthcare for inside Nigeria. How it take be, what's be the present situation, what's be the past situation, and what's be the future, or no, not the future, what's be the thing we're supposed to be. So we could look at our situation first, then how it been there before, whether it better or bad, it was past like this, and then waiting be the real thing we're supposed to be.
All right, thank you very much. Access to health right now in Nigeria is on a total low. Oh, wow. And I would say this because, Nigeria, living facilities, meaning we have both the rural areas and we have the urban areas.
Absolutely, yes.
So we have
that is people in the village and people in the township.
Very true. So now we have people living in the village areas, people living in the town areas, but you can see that access to get health care is very, very bad, especially with those in the village areas. Ours we'll call the rural areas. Now, we have more health facilities. We should have much more health facilities in the rural areas because we have more people living in the rural areas than we have living in the towns, basically in the urban areas. But you see that that's where we have, Nigeria has 3 healthcare tiers. We call the primary healthcare, secondary, and the tertiary. Primary healthcare mostly goes down to the communities. That's where we have those in the rural areas should access care from there. But we have so many primary healthcare centers that people still cannot access care through, either with dilapidated buildings, either don't have enough structures, don't have different things wrong that kind of puts a nuisance to easy accessibility of care. Now, if we want to look at it as a whole, right now, the accessibility to care in Nigeria is I have about roughly, from WHO statistics, going to about 40 to 42%. And it's said that by 2050, it's going to drop much more. That's to show you how bad it is, because you're having a lot of people doing medical tourism to India.
Not vex. So you say 40 to 40 something percent. Now me 42%. Meaning say only out of 100 people, only 42 persons fee see doctor, fee go hospital.
Access to care.
Fee go hospital.
Yes.
You mean them?
Yes.
Then the other 60 something and
many people
they feel just the house die.
Yes.
Hey wait.
Or they basically you'd see will go to traditional birth attendant, traditional bone setters. They go to traditional healers and not access care.
How successful those ones today?
Very, very minimal. There is more complications with the traditional healers than there is any success. Because by the time people go there and they come later to the hospital, they're in a worse state than when they first.
Then why people they patronize them? Because a lot of people go talk say, oh, our mothers and our fathers and go talk say, oh, they born them for traditional with TBAs, traditional birth attendants, and they don't did their sins. They go tell you say if something to do your bone, they bury the bone for leg, turn and piam, the thing go set. So how come you know they don't they succeed since with them like that and they talk say they effective?
Right now, if you want to look at the way the world is going, you see that with the kind of food we eat and the different kinds of things, our body system is changing. And the body system is not as strong as our forefathers were. So basically with different things they could do, and then they would eat things basically more from the ground, they would eat real substance food.
Including to breathe better air. Because the air
the air now don't pollute. So you said they would eat all these things and then their body system is really enriched their system. So when they would basically go to birth attendant, whatever, even if they had to break a bone, the bone would heal well. But now break someone's bone, the person is still in the cast after 1 year. The bone is because all the meals he's taking into his system is not allowing the body to properly function well. They're eating so many genetically prepared foods, because everybody wants to see how to make money quickly. So they're doing all kinds of chemicals to make the food grow faster, do this and do that, and all that affects the human body. So it affects the body's process because God as a creator created this body to heal itself. Medicine logo is we care, God heals. So because that's how God designed the body. So we can only do this. That's why you see when you do a surgery and everything, they basically do everything, clean you up and bind it up and leave it for the body itself to heal itself. So that's about when we take in food that constitutes chemicals and things that prevent this healing from taking place. You see the problem where.
So Moko, go back to that 42% where you talk for rural. In fact, this one in general, no be whether rural or urban area, whether township or village,
yes.
Be. So now continue on that line of thought where you talk say only 42 to there.
So
but meanwhile, the standard now waiting according to United Nations.
According to United Nations, you should be having over 75% of people in that country able to access care.
Yeah. So from your findings as a medical doctor, what will be the issue when people need to access healthcare? Now, because say they near them, maybe they cost too much, or maybe because hospitals not there at all. Now, waiting maybe the kukuma go TBAs or go other traditional options, take other traditional options.
Well, in Nigeria especially, there are a variety of factors that constitute all these why people don't go to the hospitals. One, possibly distance, but I'll give an example to this. For example, now in a PHC, let's say in Lagos now, you have PHC, which are primary healthcare centers, and these are supposed to be the lowest cadre of tier which everybody can easily get to. But then you see, with some study done, I think it was in 2022, they found that the closest PHC to maybe any community, many times in the community, is roughly about between 2 to 49 kilometers. So you can imagine someone who is living about 49 to 50 kilometers from the facility. He's going to think of, do I have to walk there? Is he going to drive? Or let's even put it that he doesn't have a car. He's living in the village and then he's thinking, I'm going to walk to this PHC all the way down there. He's not going to think. He's going to be thinking of, where's that Baba that sets bone and is just next door? He'd rather quickly run there, give him his child to help him set the bone before he thinks of going to walk.
So these traditional people, they're closer to them, Paz.
They are much closer to them, that's one. As distance is a factor. 1, 2, financial. They're also looking at the finances. The facility wants them to pay certain amounts of money, which they feel they don't have the funds to pay. They go to the facility, maybe the facility doesn't have any water, it's in a deplorable state. You see the roof leaking, you see broken glass, you see different things. So it doesn't even encourage the people to even want to come there, or they get there, maybe the doctor is not there, there's no doctor there, there's no nurse, there maybe just the CHU, the community health extension worker, and the CHU is, maybe she has not been paid salary, she's been paid, she feels she's not paid enough, she's very in a very antagonistic mood, and then they feel like, just leave Highland, just leave Highland. So those are different, all these factors contributes to why people don't visit primary healthcare centers, secondary healthcare centers, even tertiary. People just feel like all these things all put together, they'd rather just look for how can they easily, and for many people, for most people, especially in the rural areas, the villages, financial is mostly the top of the line. They tell you, for example, a patient comes, maybe he has a broken arm, and then he comes to the hospital and they say, okay, we have to put a POP. POP is costing 20,000. and he's thinking, he's not seeing, he cannot see 20,000. Maybe it's like 2 months before he sees 20,000. When will he get that kind of money to come and do for his child who has a broken arm?
But do you blame them?
I can't blame them. The thing is that, and you see that even with the inflation we're basically going through right now, the cost of these things are rising.
Wow.
So people are even more like, what are the other alternatives we have? Let us focus on that and see how we can use that at least to keep on living.
Okay, so say when I've been asking you the question earlier, I've been talking about waiting the situation be like before now, and then waiting it be like before. Then waiting be the ideal situation. So you don't talk about waiting it be now, right?
Yes.
Waiting be the did time where it be say been any better for Nigeria. Waiting be the previous situation of accessing healthcare for Nigeria.
Accessing healthcare when they started out the act and the different policies and different things. The goal was to make sure healthcare was very much accessible. Now, when you talk about, when WHO basically talks about accessibility of care, they're talking about not just accessibility of care. That means the facilities must be available. One, there must be enough policies and different things in place for this accessibility of care, and then there must be no financial hardship. Means that this care should be affordable for all. So you can see, I'm sure, thinking about that, when you put Nigeria into the equation, you now look at financial hardship.
We
no follow that one. And then, yes, Lagos State will say we have about 30,000 PHCs all over the place. Yes. What state are those PHCs in? How many healthcare workers do you have there that are fully functional? What are the facilities they have there? Is there water? Is there light? Do they have basic medical equipment to work with there?
Okay, so speaking about medical equipment, and then with question I asked you before, you feel, say, this whole trend of people we don't japa, your follow medical people we don't japa, follow costs make the situation worse as it did before? And waiting for your opinion, we make you think, say, a lot of your fellow doctors and they come off for Nigeria.
Now, a lot of doctors, answering your last question first, a lot of doctors have left the country mostly because they feel, I don't think it's majorly the money issue. The money issue might be there for a few. But I think a lot of the things have to do with accessibility or proper medical equipment to work with. A lot of people have had situations where they don't see, trying to believe that the healthcare system would develop. I've made requests to government to bring better medical equipment to combat certain things. Many people doing research, and they just can't see. People write papers and say, okay, we need to do this to be able to reduce the infant mortality rate, the maternal mortality rate in this country. We need to do this. And they don't see the government movement, and everybody picks it. Okay, we see that. What's the cost of getting this? Is this okay? Let's just hold it aside for now. And they see things are not moving, and they feel, this country, this is how they want to be. Let's move on and find better. So I think more of it is one with better working conditions. Better working conditions. So the greener pastures here don't have to all just be financial. Better working conditions, better life for them, better ability to be able to progress, move forward. Just recently there was a demonstration in Nairobi for nurses. And the nurses were having a demonstration. This is about a week ago. A week ago, Tuesday, last week. They had this demonstration because when they did the promotion and different things, only a few nurses were promoted. Maybe in it recently just had like 3, 4. And a lot of them ready for promotion. And one, maybe Bobi doesn't have the opportunity to promote a lot of them because there's no space to put them all. And then so they only promote just a few. And everybody's wondering, we've been working at this level for a long period of time. We're supposed to have been promoted. Why are we not promoted? And then they say, okay, they'll look into it. They'll do this. And they shut the place down because without the nurse, clinics can hold, theaters can hold, different facilities can hold. They're the ones that manage the wards. And so you see all these things all put together. So doctors leaving the country, so many things happening, so many avenues to be able to want to progress, to be able to get better things working for them. And then there's also the money part. So
you feel it also help affect the accessibility of healthcare?
It totally has affected it and will continue to affect it because we're only seeing the beginning phases of it. We've not seen what's going to happen, the rebounding effects is going to happen.
So that means it go worse past like this?
It most likely will get worse They always tell you it will get worse before it gets better. So they'll tell you expect the worst.
Oh, wow.
But the worst is still yet to come, because now in 2022, WHO statistics of Nigerian doctors was 24,600. I can tell you that number, I'm sure we've reduced by 50%.
By half.
Most
That means if you just get about 12,000 for 200 and something million. I mean, our population too, by the same United Nations, should be about 228 million.
Yes, so you can imagine.
By this year.
And
Are you
I can
serious?
tell you that much more doctors are also still planning to leave.
Oh, I have one who's planning to leave.
Sorry?
I have one who's planning to leave.
So you can imagine. So what's the government? Yes, the government says, oh, we'll do. See, if you don't start, they say, what you will be in 5 years, you start planning it out now. If you don't start the planning now, you would not, in 5 years, you see that you're still at the same stretch you were 5 years prior.
Okay.
So government needs to start now. What we need to start putting on, for me, solutions coming into all this really have to come into with policies. They need to start pushing in things. Start with policies, then coming together to form strategies to begin to start pushing these policies out into effect, then go into digital health innovations. That's the thing, you see, first world countries are into and are really pushing these things out. They need to...
People don't use AI safe.
And you see the way AI things are now, in advanced countries, AIs are doing surgeries for people. You don't see doctors even doing, you see it's AIs that are doing people's surgeries. So the world is moving so fast that many times, I was talking with a colleague in London, and he was saying, do you know that Nigeria is like 20 years backward when it comes to medical things? And it's like, what are you still doing there? But that is just seeing the thing, because when you go outside and you see so many advanced things, you're like, when are we getting to this level?
I will come take you on that backwardness, because speaking about backwardness, I want to know how obsolete equipment, then that is equipment we don't pay and not getting the right equipment, how the thing they use affect accessibility to good healthcare for inside Nigeria. But that one will be after the break when they come back. Welcome back. Nice on top. Good morning, Nigeria Extra and you day. And before we go on break, we'll be look at how person feel to access medical care for inside Nigeria, waiting the challenge and be. And Dr. Paul here don't help us break the matter down on waiting the challenge and be. But one challenge I've been telling you, so I'll go ask you before the break now. Why you smile? You be like say you know say that one a very matter way you did God hand. You did God hand because you don't get solution. So we know say you just just before we go on break, we will talk about technology, how people don't embrace technology. They don't even use AI and all that. How using equipment we know the up to standard if it affects people from or avoid them from accessing good medical care.
All right. Not having up-to-date technology on certain equipments, how it affects healthcare is one, it results to late diagnosis or wrong diagnosis gotten. One with the lab, so if you don't have properly designed, high functional lab equipment, when you run blood tests, what you're looking for most times is not what you'll get. And you tell the doctor, oh, this is what I got. The doctor starts to work based on what your assessment was, and he's treating wrongly.
So you know why I ask this question, no vex, because there are places abroad where you say when you travel, people will go Bodo. When you go Bodo, if you just complain for one thing, because of that one thing
they find so many other things.
Because of that one thing we complain about, they could just do only one test, one where they could do. They could see different things where they say they worry you. But here, you go do test A, B, C, D, E, F, G, Z. You go plenty. That's they one side. Then on now go can't kill the person with exam question. If they do you like this, how they be you like this. So waiting that's that's on our olden day style. They fit cost to delay person from accessing good health care.
Okay. One thing I like about the Nigerian healthcare system with this, so if you don't feel like, oh, I'm just saying so many things to kill, but I love the Nigerian healthcare system with this part of what I'm going to say now. We deal with evidence-based medicine, and mostly, when I say evidence-based medicine, I mean common things occur commonly, and we are more based on, we ask questions to get to a diagnosis. Abroad, it's not like that. Abroad, for them to get to a diagnosis, most times they have to run tests. Now, with evidence-based medicine, yes, we will run tests, but it's based on our possible diagnosis of what we think the problem might be. So we ask you questions, we want to know how you're feeling. So the answers you tell us, we're already formulating a possible diagnosis in mind. Then we'll run tests based on to see what possibly it might be. Oh, okay, if it's this we see, then this is cancelled out.
Meanwhile, your mates in the other part of the world, they could just touch one thing, then they know what's in the problem.
Thank you. So what they are doing now is they're not asking any question. You want, okay, run, yeah, enter, do CT scan. Then they will now look at what your result sees and says, oh, okay, we are seeing this, it's possibly this. They start treating on this, okay, no, let's do another test. Now, so, but they have the advanced equipment to do many of those things, which we don't have here. So our system of, and I want to applaud our system in that even with the lack of equipment we do have, we still do a lot of good work, a lot of good things, repairs and different things we do. Many times when I've seen even international people come and they say, you guys still do this, and they're wondering like, they did this maybe 20 years back, but then they see the effect and like, wow, you guys are really good with this and we've stayed on that and we've almost maybe like perfected it, but we still do good work with those things. So you see that I believe really that one of the major solutions is with the event of digital health innovations and different things, if we're able to invest a lot after doing the policies, the strategy, we're able to invest in technology and then be able to provide these equipments that it's not, I know the thing about these things and also is that equipments like these are very expensive. For example, I'll give you a rough estimate. For example, to get an MRI scanner, and I'm just giving you, this is per country, an MRI, which
for brain or for total body MRI?
No, it's just an MRI. It's an MRI machine. So it can do the brain, it can do different scans. It's just an MRI machine. An MRI machine now, if you want to order it from, like, let's say we use a Siemens now, to order it from a place like Siemens or China, wherever I want to get it, it roughly, as of 2 years ago, it was about $40,000 US. Now, roughly, you're talking at about possibly between 80 to 100,000 US dollars. Good.
Oh, wow.
So you can imagine.
So that means almost 100 million or 120, 150
million. So you can imagine people that have those machines, why they charge as high for the cost for those things.
Wow.
And then the different what's it called? Equipment that need to be used, with the X-ray films, the different things they need to purchase, which also have expenses on each. So for healthcare, it's an investment in the sense that that's why you see with places like the US and so on, the government is really big on investing into healthcare to make sure it works. So this is where I talk about policies that government has to really be invested in this to make sure the best equipment comes in.
Talking about government being invested so that the best equipment could fit the involved, why is it so difficult for us to get them? I feel, say, for instance, the crude oil we get for Nigeria will be our major source of income apart from tax. Now, we government not say it could be our source of income. And the same crude oil we United Arab Emirates, Dubai gets. And Dubai don't use that same oil, turn around their fortune. Accessing this thing with government, not because of say government don't get the money or lack of interest or lack of knowledge to use drum. Because why it would be so difficult for us to invest on things will go help us save the lives of our own citizens. But meanwhile, these things are things we be say if they go abroad, them they go abroad if you access them. I'm not tell you say me answer the question because I know say you want to run away from politics question. But because it get as a bit to hear say we know the fit get these things. And meanwhile, we get the resources to fit use achieve them. But make we just go straight to other matters we still get to do with this issue of getting equipment and how the equipment for use affects people. Make we look things like electricity. Waiting be the things we be say electricity or lack of electricity fits how it be say fit improve, enhance access to medical care or to fit use make kukuma dabaru finish. The reason I ask you this now because of say I don't do different situations where be say they carry torchlights to people surgery. For federal government hospitals, torchlight. I don't want to tell you to be victim. Do you understand? It they happen different occasions, and it is embarrassing for that to happen. So make I let you answer those questions.
Very true. I actually have been in a surgery where torchlight was actually used to operate the surgery.
Shame no catch you small.
Shame catch me plenty, but what do you want to do? I mean, only the patient, make the patient back. They have to do it. And that's why
I say they carry smile for your face, they talk am.
No, but I applaud.
It's supposed to they cry small as they talk am.
I applaud even the surgeon we even talk say, because on a normal day, person no go want to do that kind of thing.
Hey.
Why would I have to carry torchlight and be operating someone? But then for the surgeon to say, see, this patient's life is worth this. I'd rather do this. It's a very deplorable state for him. He's going to be sweating, he's going to be doing everything. And then they're mopping his face while he's doing the surgery just because the doctor is sweating profusely. All in a the theater is such built that there's no like windows or things. So,
absolutely, I know that.
Yeah, so you can imagine, but he's doing that because the patient's life for him is dear. This patient, if he doesn't have this surgery, dies. So there are things in which, but then now, for that, now you can see this doctor now is working in the most deplorable of solutions, in the most deplorable of situations, because there's no lights. Then the hospital says, I'm not going to mention it, but the hospital says there's no diesel in the generator. They are owing PHCN or they are owing NEPA a lot of money, so NEPA is not giving them lights, and then they don't have any solar. So what happens? But people are rushing to the hospital, coming, I have this broken, I had an accident, I had this, I had that. And then you can't just leave them be. You try to send them, maybe in the government, okay, go to a private hospital. They go to the private hospital. Some private hospitals, when they see some cases, feel, this case passes, please go back.
The government, I send them come on.
But then that's the...
They can't hang for air.
Most times, if the government is going to send you to a private hospital, is that possibly, let's say there is no electricity in the hospital, the entire hospital, and they feel that you being here will be what all, they give the patient the opportunity to say, would you rather just go to a private hospital so you can get yourself looked at quickly? So
these things don't cause avoidable deaths. It don't cause people who are not supposed to die to die. Very true.
Presence of electricity and everything, all these can prevent deaths. Good water source, even technology, even in the hospital too, can also help bring about better accessibility to health.
Very, very, very sad. All right, my people, now still on top of the Good Morning Nigeria Extra now we day, and we talk about access to healthcare for inside Nigeria and the things that we fit do to make sure say it move forward. The kind of news and what they hear, the thing they turn my belly well because I don't even know where I want to start from again. But I could take this break. When we come back, we'll go look whether solution even did this problem. That light so they say they at the end of the tunnel is still there for this matter. I be they don't quench them. That's now after the break when they come back. Welcome back. Now, still on top of the Good Morning Nigeria Extra now you day. And we're with Dr. Paul here. He don't tell us about the different challenges and way people they get to use access medical care for inside Nigeria. And we don't talk problem plenty. But now one great man we be seeing be philosopher and I talk say the solution to any problem to realize first of all say problem day. So when we don't identify say problem day, but make we even go dig this problem from roots. Not vex. As they use the teacher now for medicine one on a day school. How often did they upgrade the medical syllabus for inside Nigeria to use, add all this new technology and new invention for medicines them and new angle for medicine where don't they enter? Would they do it for Nigeria?
Very rarely done.
Oh wow.
Very rarely done, and this still points to...
That is when I still learn what I learn for waiting 1825
and... We still use the same textbooks in which they give you upgraded. Let's say you're using Common Clark, you're still using maybe the 20th edition, and it's basically still revolving around the same thing.
So the syllabus never changed.
They'll tell you even many times when you're taught in med school that, we're told many times that, okay, many of these things you will not see them, but you're supposed to learn them. Why are you teaching it if you're not going to see it? Teach us what we need to know and how we can combat this thing. So many times you're taught things are cake that you really don't need to know. But the things that you need to know that would help the next person, possibly maybe more recent listeners, you don't get them. You most likely, maybe if you go outside postings or you go abroad, different things, you begin to see other things and say, oh, I didn't see this, I didn't know this. And then there's also this part about that in medicine, you're taught that we're in the tropics. So it's tropical medicine. This is confined to the tropics.
Tropical medicine. It did the medicine where they define to...
Because yes, I'd say this part of it, just like now, somewhere like malaria is not abroad, it's not because it's not common. Malaria is more called a tropical disease because it's more with the tropic area. So it's thought.
So I make agbo, now the kind of thing if you solve a malaria for us. But you know, I want also look at, before we go to solutions, I want to also look at the dangers, if there are any, of self-medication and maybe other traditional practices. So dangers then they at all, or now all gains, or maybe you just want hands off for inside that matter.
There are plenty dangers.
But the solution also the day, because the solution no the people for need to do. Remember, say before when I bring on our Igbo medicine come, now that's medicine that our forefathers and use exist.
You remember when I told you about our forefathers? Their body systems and ours are totally different.
Yes, I talked so.
I talked about the food we eat, how it has distorted
even the environment generally.
The environment also. Now, for example, our forefathers might have been using agbo in their days. Agbo is basically it's herbal concoctions.
Absolutely.
You basically will just take some herbal, these things, grind, put in this thing, you see the
boil
it, and then they drink. And then for them, it cleans out their system. Nowadays, when you take agbo, you know what it first does? It kills your liver.
But not vex, so why it go kill liver? But meanwhile, people like China still don't adopt the agbo in a more refined way into their medicine.
So what they have...
it be like say their traditional people and their medical people, they work hand in hand. How then we take infuse and we will not feed our own like that?
So now what they have done is this, because there is because when we're taught pharmacy and pharmacology, you're taught that there's what we call an LD50. LD means lethal dose. So there's a certain amount of dosage that your body can take. But when you're taking agbo and you just grind it and you drink the whole thing, you're drinking the whole 100% constitution. But when we talk about when you're taking tablets, paracetamol and things, that's why I don't know if you've ever heard, do you know there's something called paracetamol poisoning? People who want to kill themselves many times just drink a lot of paracetamol because they go over the lethal dose for paracetamol. That's why they tell you paracetamol, after you take it 1-2 days, stop, consult a doctor.
Not true. And I hear something they scatter liver too.
Because it kills your liver. There's a certain dosage you must not go over because it will kill your liver. Okay,
so you know, we could talk this matter. So things like maybe, my pikin no well, maybe break leg or break hand, or I carry and go, maybe twist the leg, maybe it's incorrect. This is the move we don't do before. So what thing will come make and dangerous now from when it work for us?
Because the thing is that there are certain things with our body system that if you're not made aware of it, you can cause more harm than good.
Give us an example.
For example, a 3-year-old boy recently had his right arm amputated. Why? Because he fell down in his compound, broke his arm.
Just normal play with picking
normal play.
Can't break hand.
Broke his arm, and then the neighbor decided to take him to a TBA. Took him there, and then he set traditional
bone setter.
Bone setter, set his hand,
then
very tight with some distance, put sticks there to tighten it. But what he didn't realize was that in tightening all that was occluding blood supply to that arm. So that hand for the next 5 days was in that position. I told them they should keep that boy's hand straight that way. They said the boy was actually in the bone setter's place. They kept him there with him. For 5 days, that hand became black, got gangrenous. By the time the mother went to pick him, that hand was swollen, was almost getting rotten. When he came to the hospital, the doctor said, you have to amputate it. That hand is already gangrenous.
Yeah. Became when them bone complete,
So you can see that it's nuts. In those days in which maybe traditional bone setter would have set it and done, but then different things now, you have to understand, because I'm sure the bone setter did not understand the anatomy of the hand, that there are blood vessels going, and blood vessels are going to supply every part of your hand. Even if you want to set it, that's why you see when we set a cast, it's not done too tight because you don't occlude this, when you occlude blood to certain areas in the body, you kill that substance, because blood takes oxygen and nutrients to that part of the body. So when you occlude and restrict, for example, if I tighten this place so tight and blood isn't going to this part of my finger, you see that this part of my finger starts going black.
And by the time you know, you're not going to get feelings for that.
You don't have any feelings, it's dead.
So this is one of the dangers then.
Yeah,
so what's can be the solution because of time so that we'll fit go? In fact, solution D, and what's be the solution? And what's be the possibility of this solution working for the Nigerian tropical situation?
The solution, first and foremost on the list, government has to get fully invested in healthcare. Healthcare has to move from being number 6 to 10 on their list to number 1. Meaning,
because now who they alive first.
Thank you. Now who they alive, you can govern. You can tell, do this, do that. So they have to push healthcare to number one. And then first starting with policies, advocacy, setting up strategies and putting people to run these things fully, making sure health digital solutions are put in place, digital instruments, different things are all put in place so that we can have these things working effectively. Government majorly. Then there's also got to be a handshake between government and the private sector. Right now, yes, in certain places they try to, but right now both sides are working individually. You have the private institutions doing their own part, wanting to, and then you have they've got to give a handshake to be able to help the community, set up certain structures together that will be able to help provide healthcare to the masses. Because in the three tertiary of healthcare, as I said, the primary healthcare, government majorly controls that. Government has more of it. But in the secondary, the private sector has much more. You have general hospitals and majorly the secondary healthcare, but you see more other hospitals are private hospitals than you see general hospitals. And then the tertiary, which are the teaching hospitals, is government. So government is more in 1 and 3. Number 2 is the private sector. Why can't they both have a collaboration to make sure they are all in all three and they put hands together to make sure that all these health facilities are adequately getting to each and every corner of the country, to all the masses?
Including those rural villages and the village, the way we say you talk.
True.
So if you say this one a good solution to use help us with the program, and you think it is possible for the Nigerian situation?
It is very possible. We need is to have someone who sees this as his priority number one. He puts all his attention into this. He puts the right people in leadership to make sure they drive this. And once this is, it might not happen in the next 1-2 years, but you'll begin to see changes happening, because to be able to see these changes in the institutions, you must be on the road and you begin to see things happening. You begin to see, oh, government is telling you every 1-2 years we have an act, health act, this must be done. You see, when you see certain acts must be changed, you see in the years they're carrying placards and you see government, everybody goes back to sit and look. I can tell you, I gave a seminar presentation, I think at one of the banks, and then we're talking about mental health. Do you know there's not been any mental health policy in this country since 1960 something? So all the mad people, all the people who have mental issues, there's nothing concerning.
A psychiatrist, just the head of psychiatrists for Nigeria, just talking recently, say even more people don't, dive into mental issues.
So as I say, government needs to be fully invested. They feel they are not. They need to be so 100% fully invested into this.
After all, our money will give them to manage, Abi. Thank you plenty. As you don't talk this one, Dr. Paul Kusemiju, I get them right, Abi. Thank you as you follow me, sit down for Inside the Studio. I appreciate it. Hope so next time if I call you, you will come.
Sure.
Thank you. Thank you plenty. So, my people are here now. Go draw the curtain for Inside the Show today. Abi will go kukuma end the show. Abi, so I go come your TV again another time. Thank you so much. As you follow me, stay today. My name is Precious Enyi, and well done.